We're going to go over a little capnography today. I'm just going to be refreshing for most people. Um, Capnography never changes; it's always the same. There's nothing new that comes out of capnography. It's just you learn about it, and that's it. Capnography does a lot of things for us, especially upon intubating the patient. It can tell us just how sick our patient is, whether our tube's in the right place or not, all by the waveform and the numbers we get. Big difference with capnography. We're going to understand the difference between oxygenation and ventilation. This is something that we do need to know. Anybody tell me the difference? Okay, oxygenation, just air coming in and out. Ventilation actually causes the metabolism, causes the air exchange to the alveoli.
Turn them around. Your dyslexia is kicked in. Your dyslexia kicked in. Ventilation's air in and out. Oxygenation is metabolism. Okay. I do it. I'm sorry.
All right, so here's just like a little ventilation comes in, goes around it. We have the cellular metabolism, comes back out with the CO2. All we do is trade out oxygenation for trash. Yeah. Pulse oximetry measures oxygenation. Capnography measures ventilation. Provides a graphic waveform available to interpret in order to help you assess your patient. So what are we looking at when we have somebody that we think we throw them on there, have difficulty breathing, and their end tidal is like 70? What are we thinking could be this patient's like past medical history, or what's going on with this one? Might give you an idea. Hyperventilation? You sure? Hypoventilation. Now, they can be hyperventilation if they're not moving any air, if they're air trapping secondary to COPD, emphysema, asthma, something like that. You can also increase your CO2. You get your little short burst of air where you're breathing 40 times a minute, just not doing you any good. Hypoventilation, usually, especially people that's unresponsive, is the correct answer. Secondary to they're just not moving enough air. Now, hypo capnography, low, what are we looking at? Usually, we're looking at somebody that has pulmonary edema, CHF. That's one of the things that I do on every patient that I do. If I'm unsure of what's going on with them or why they're going, I always put a CO2 on them just to see where their level's at. If they come back to me at 23, 22, 24, I automatically think, okay, this is not going to be something I'm going to give albuterol to. Even with low, I don't know how the docs do it up here, but even with low CO2s, we automatically think of pulmonary edema fluid. Usually when you give albuterol, it exacerbates it, opens everything up, and you just flood them with pulmonary edema. Last thing we want to do to this patient. So you have this patient has end tidals of 23, 24, but they have some expiratory wheezes going on. We want to go ahead and treat these expiratory wheezes with albuterol. Secondary, that our alveoli are still clamping down on the upper lobes, but the lower lobes are full of fluid. Now, that's going to be a personal decision on your side because you're able to treat the wheezes and you're clinically, it's the right thing to do. What's going to make the difference if you treat this patient or not with albuterol? I guess is what I'm asking. History. Is your oxygenation good? Is it above 94%? That's my goal. If it's above 94%, I'm not going to give them albuterol. If it's below 94%, a lot of times I'll go ahead and treat them with like one dose of just albuterol. But in my back of my mind, or just because I'm like, okay, go ahead and get the tube out, set it on the counter. We're going to get ready for our backup airway just in case I flip people with pulmonary. Have I done it in the past? Yes, I have. I'll be the first to admit. It's like, you know what? This is what I want to do. I give them the treatment. Here comes the frothy pink sputum coming up out of their nose and their mouth. Okay, maybe we should have done that. But we can fix it with positive pressure ventilation. Oxygenation is measured by pulse oximetry. Pulse oximetry, it's a non-invasive measurement. All it is a percentage of oxygen in one red blood cell. Changes in ventilation takes minutes to detect on a monitor. This is affected by motion, artifact, poor perfusion, and some dysrhythmias. Will give you poor O2 saturations. The purpose of this that I do not like is it takes minutes to detect if it changes. So your patient, if you got them oxygenated, your patient can stop breathing for 5 minutes before that thing even starts to measure down. Your patient may not even take a breath. That's just the pulse ox waveform. Everybody's seen that. Ventilation is measured by the end-tidal CO2, the partial pressure or volume of CO2 in the airways. That's at the end of the exhalation. Respiration measurement provides information within seconds. Within 10 seconds, you will have a new answer, or a new waveform, or a new number. Not affected by motion artifacts, or perfusion, or dysrhythmias, which is the good thing. I think one of our biggest things up here is cold fingers. Especially this time of year, you just can't get good saturations on them. Another thing I'd like to talk about real quick before we go much further is our nasal cannulas. I haven't found a really, really good way for the nasal cannulas to actually read correctly. I don't know if anybody else had. If I would love to freaking share it because I tried everything under the sun. Anybody have any ideas how we get these nasal cannulas read correct?
I don't know what makes a difference. I just asked them to try to breathe in their nose out their mouth.
That's what I'm gonna do too. I said, hey, can you just exhale out your nose, exhale out your mouth? I tried it both ways. They're so when you first put them on, you'll get a low reading, and then all of a sudden it goes back up to normal. Then it'll drop down to 15. Then it goes back to 24. Just I don't know if there's a really good way. I've even tried putting them on and putting a mask over them, leaving the whole out of the mask so you have a good exhalation vent. It don't even work. The only one I think is true that you can come on 100% is going to be your end-tidal of your ET tube. That's just capnography lines. Okay, so oxygenation. Oxygen for metabolism, SPO measures the percent of O2 in red blood cell, reflects changes within 5 minutes. Ventilation, end-tidal CO2, measures exhaled air, reflects changes within 10 seconds. So oxygenation versus ventilation. And anybody can do this. If you want to go back to your station and try this, it's pretty cool. Put an SpO2 on your finger and quit breathing. Take a nice breath of air and you just stop breathing. See how long it takes that thing to start changing down. Where you get a number. Then get you an ET tube, breathe in and out a bit, quit breathing and see how quick it changes. And you'll see it. The SpO2 will take a couple minutes before it starts changing any kind of numbers. You'll actually have to take a breath of air before those numbers move. It's kind of says the same thing I just said. You remember reading a heart rate over 100 waveform? It's kind of what you have on the bottom there. It kind of follows throughout. So, why measure ventilation in intubated patients? Verifies and documents ET tube placement. The number one thing that we have is that waveform that lets us know that our ET tube's in the correct placement. Whether it be a little shallow or a little deep, you're still going to get a waveform. You're still in the trachea. That's what we want. Immediately detect changes in ET tube position. So I know a lot of us do and leave it on when we change them over to the bed of the ER. I try to, but the simple fact is I can look at that waveform once we move that patient because, you know, nurses are great out here, but if you're not grabbing the tube to hold it in place, nobody else is going to that's out there. And they'll just grab that patient and rip them over. You can assess effectiveness of chest compressions with end-tidal CO2. Earliest indication of ROS. One thing we were doing in Texas is you didn't have to feel a pulse. If you've got a ROS jump, our medical directors were like, stop right there, you have a heartbeat. Regardless if you can feel it or not. At that point, we started pushing the epi drips to try to bring it up to where we can actually palpate it. Is without a ROS, if you have a ROS jump, you have a heartbeat. Indicators, probable of success, resuscitation's up. You can adjust your ventilation to your patient for your sensitive CO2 changes. If you're running a little high, just increase your breath rate or increase your tidal volume, whichever one fits the patient better, in order to get that back down between 35 and 45. This is a little study, a 2005 study for field innovations. They didn't have, I guess, any on the waveform, and 23% wasn't effective with non-ECO2 monitoring. That was still left as good. So with the end-tidal monitoring, they had 0. So injectable excess and acute respiratory disorders, asthma, COPD, emphysema, possible gauge response to treatment. Like we were saying earlier, anytime you have emphysema, COPD, or asthma, you're trapping air. We can get air in, we just can't get air out. This is the problem with these patients. At this point, you're going to have elevated end-tidal CO2s. Anywhere from, anybody know the gold number to intubate your patient with your CO2? 70. If you have an end-tidal CO2 of 70, any ER in the nation should intubate that patient immediately. Because medicine at that point is pretty much not effective with them. Take some time. So, some hypoventilation states. So we're going to have some still increased end-tidal CO2, drug or alcohol intoxication, congestive heart failure, or the other way around, sorry, congestive heart failure, sedation, analgesia, stroke, head injury. What's all in common with these patients? Level of consciousness, and what's their breathing pattern? Either irregular or slow. Head injury, we're looking at Shane Stokes. It's kind of a little different. It can go fast, and you're going to have your slow processes. Drug and alcohol intoxication, usually going to be slow respiratory drives. Congestive heart failure, once they get to the point that they are in full failure, like we were saying a while ago, what happens? Pulmonary edema, respiratory drives, or respiratory starts slowing down. In that case, that's where we have that flip that you were talking about, where the end-tidal will go up instead of down. Strokes, once again, it can go either way. If you have a stroke that's in the brainstem, they're going to be breathing really fast. If you have a stroke that's normal, the respiratory drive will slow down, their end-tidal CO2 will increase. Pulmonary blood flow, I mean, this is just kind of coming in from the right ventricle. You're going to go through your oxygenation. CO2 will come out. Oxygen goes back into your system, goes out your pulmonary vein into your left atrium. Did anybody tell me what the gradient does? Just measures your blood oxygenation, I believe, between your alveoli and your arteries. Gives you that partial pressure. And as you see, as it comes through, once again, the right ventricle, you have your PaCO2, your end-tidal CO2 also make that flip, which goes in the pulmonary vein and back out the left atrium as well. Anybody tell me what the I guess that's partial rate pressure. Never mind. So a normal, and this is wrong, and I've changed this 500 times, and I don't know why it won't stay. It's actually 5 to 10, not 2 to 5, between the end-tidal CO2 and the PCO2 in patients with healthy lungs. When you start getting patients with diseased lungs, that number actually comes closer together. Wider differences found in abnormal perfusion or incomplete alveolar emptying or sampling. So instead, again, it goes the opposite direction, gets wider, not narrower. Anybody lost? Going too fast? So reflex changes in ventilation, movement of air in and out the lungs. Diffusion is exchange of gas between air-filled alveoli and pulmonary circulation. And of course, perfusion is circulation of blood. So monitor changes in ventilation. So with asthma, what do we got? Okay, you will have sharp ends. Asthma, COPD airways, edema, foreign body, stroke. What are we looking at for ventilation changes? Anybody? Not much air movement. Air travel. Diffusion, pulmonary edema, alveoli damage, CO2 poisoning, smoke inhalation. Getting our alveoli filled up with junk. Perfusion, shock, pulmonary edema, illness, cardiac arrest, and other severe dysrhythmias that affects our circulation. So, an increase in tidal CO2. So we have some increased muscular activity, shivering, malignant hyperthermia, increased cardiac output during resuscitation, bicarbonate infusion, tourniquet release will do the same. Effective drug therapy for bronchospasm and a decreased minute volume. Decreased in tidal CO2, decreased muscular activity, as the muscle relaxants, drug overdose, hypothermia, decreased cardiac output, pulmonary embolism, bronchial spasms, increased minute ventilation. So we're going to interpret the entitled CO2 by measuring in physiology of capnography waveform. That's all what we're looking at. I mean, the numbers are great, but we actually want to see the waveform and what they represent and the phases of the waveform and what those phases tell us. Like a normal waveform in one respiratory cycle, and this is exactly what it looks like. A nice ventilated patient. It's not rounded. It's nice and flat. This is perfect for everybody. This is exactly what we want every patient to look like. It's not what happens in life. So our first upstroke of capnography in phase 1 is going to represent exhale gas from the upper airways. This is also secondary to dead space. And something we need to remember when we're doing our end-tidal CO2 monitoring, dead space is a big thing. Dead space can come from vent tubings, all your upper airway that's in your oral nasal pharynx, all that is dead space. None of that counts for anything when it comes to your end-tidal CO2. It can actually, if you have too much dead space, you can have false end-tidal CO2 ratings. Like the old Y section that used to come out and they used to branch off into the Ys, those type of old ventilators. It was horrible when it comes to end-tidal CO2 ratings. Transitional phase is going to be phase 2. From the upper to lower airway ventilation tends to, despite changes in perfusion. Phase 3 is going to represent the alveoli gas exchange, which indicates change in gas distribution. So all increases in the slope of phase 3 indicates increase of gas and delivery, absorption. And we'll show you here in a minute. It's going to go through the phases and it'll show you everything again. So waveforms on the screen and printout may differ in duration. On-screen capnography displays waveform is considered to provide adequate information and a 4-second view. Printouts in real time observe R&R on the device. Printout's always going to be your more go-to because it's more live. Your screen, like I said, is only a 4-second view at that point. And here's, it'll start showing our different phases here. Capnography detects CO2 from ventilation. No CO2 present during inspiration. Of course, your baseline is normally 0. So what happens when we take a breath? So here's where we start exhaling. Here's where our phase 2 and 3 comes across. Right here's our end-tidal. Right here's where we're going to measure. This is our number 1 from our CR2. As soon as we take a breath, this is us inhaling air, drops back down to the baseline. This again, we'll go through the dead space here. Beginning of exhalation, no CO2 present. Air from the trachea, posterior pharynx, mouth, nose. No gas exchange occurs. This is our dead space. Here's what I was talking about a second ago. All plays a role. So here's our baseline, begin exhalation. This is going to be our phase 1. CO2 from the alveoli on phase 2. Begins to reach the upper airways. It's mixed with some dead airspace. It's going to cause a rapid rise in CO2. And that's that right there, phase 2, between B and C. Phase 3, CO2 enriched alveolar gases now is in play. Uniform concentration of CO2 by the alveoli, the nose and the mouth, between C and D. That's our plateau. The end of the exhalation at phase 3 is the highest concentration of CO2. That's where we're getting our end-tidal CO2 measurement from. Normal is between 35 and 45. It's the number that we're hoping for on the monitor. And that is the end of our exhalation. Phase 4 begins when inhalation begins, oxygen fills the CO2 quickly, and it quickly drops back to 0. And that's our full respiratory cycle for capnography. So normal range between 35 and 45, 5% volume. This is what we should look like on a good day when life is perfect. That's what we should have. Is this what we get? So
Earlier you said that if it's a COPD patient or somebody with respiratory problems like that, that it would be different. What would be a normal for a COPD patient?
COPD patient runs off, most of them run on the oxygen drive. So your end-tidals may be slightly elevated into the 50 range, but anything up out of the 50 range, people can't do it. Your body can't tolerate. That's the reason at 70, even with severe COPD and emphysema patients, even the magical number 70, they still knock them down to it. And the sad part is they can be 90 years old and they hit that magic number. I mean, there's nothing you can do for these folks. You can try to put them on BiPAP, CPAP. They can't tolerate it. Just don't work. The lungs just can't make the gas exchange. I mean, it takes a buttload of medicine and it takes it over time. And when you do BiPAP, CPAP, you can't have that time for 7-8 days. It just doesn't work well.
So if they're respiratory patient with an illness like that, we're okay in the 50s. Like we don't need to do anything.
I watch their O2 measurements, watch their CO2, make sure it doesn't increase. And also look at your patient. If they're struggling to breathe, that's not their normal. I mean, that's all I can say. If your patient, if they're sitting back, and talking to you, Stephanie, I started having problems breathing today. And it started about 8 o'clock, and it's gotten harder over time. They talk to these long sentences for you. and their entitled comes back at 52, probably normal for them. If you go up onto them, they're going, and their O2 is 52, it's probably not normal for them. My best advice that would be to assess your patient and treat accordingly.
And don't just use one reading. Use your pulse ox, your CO2, your patient's blood pressure, your everything.
Yeah, a full assessment. I mean, assessment's the biggest thing, the best thing we can ever give our patient is a good assessment. Without it,
That white notebook over there, you might start off a roster on it.
do what?
There's rosters in that white notebook. Just thought of it.
So how would your capnography change if you initially started the breathing rate at 30? So what would it look like? Your frequency, duration, height, and shape. I mean, what would you expect to see if your patient's breathing 30 times a minute? Or even 40 times a minute? What would you expect to see on a waveform?
What would you say?
If your patient's breathing 40 times a minute, what would your frequency, duration, height, and shape be of your waveform? I'm just going to make you think before we go into it. Yeah, okay, your cap would be low. Okay. How about your width? Smaller, because you're breathing faster. Your shape? Going humps. Just like that. Yeah, the height's lower because you're breathing faster. Because you're blowing off CO2, so it's going to bring it down from the 45 mark. And it's narrower because you're breathing faster. And you have more breaths, so you're more compacted. And that's one way too, we can tell if you don't know how quick your patient's breathing, and you don't want to sit there and time them out, throw them on CO2, couldn't tell you. Tell you right there how quick they're breathing. Count them out. So, increased CO2 deficiency, hyperventilation, decreased pulmonary perfusion, hypothermia, and decreased metabolism. Interventions: adjust your vent rate, evaluate for adequate sedation, and evaluate anxiety, of course, and conserve your body heat. Decreased pulmonary perfusion. What's going to cause that? Number one thing that decreases pulmonary perfusion. Huh? Edema can. Rainbows. Saddlebag PEs. So how would it change if your patient went from breathing 20 times a minute, which is nice and pretty, to breathing 8? Now what's our CO2 waveform going to look like? Wider, taller, and slow. So if you're sitting behind your patient and this pops up on your monitor, it's the first thing you want to do. Assess our patient. Let's get them some O2. Let's help them breathe back up.
Breathing 8 times a minute, bag them.
Breathing 8 times a minute, bag them. Yeah, this is the same thing we did just a second ago. So we have normal, we have hyperventilation, we have hypoventilation. These are our basics that we run off of for waveform capnography. So if we're having an asthma attack, what's one of the first things that we notice about our patient? Are they breathing fast or slow? They're trying to breathe fast because they're trapping air. Okay, so we're trapping air. So what's that tell you? You're breathing fast, so your entitle is going to be Be careful.
but it's trapped.
There we go. You're gonna be faster breathing, but you're trapping air. So bronchospasm hampers ventilation. Now they're like unevenly fills on inspiration. That's the whole kicker right there. Unevenly filling. Empty and extending increase during expiration. Alter the ascending phase of plateau slower and rise of CO2 concentration. Parasitic pattern. What we call a shark fin is a type of shape waveform. So what's this here?
Isolation.
Okay, this is considered to be what though? Dead space. Okay, so here's our plateau. Here's what we're mixing with enriched CO2. What's happening here? You see how that's uneven and it's not level. It's kind of going up at an angle. That's because we have unempty dumping of CO2. And as you see, since air trapping, what's happening with the CO2? It peaks, it's starting to raise. We're starting to get an increased in tidal. And of course, with our inhalation, straight back down, no problem getting air in. The problem is getting air out. And the reason you know it's a problem getting air out because this plateau is going at an angle. So when you pick up your next patient that says, hey, I'm having asthma attack, you can throw them on there. If you see shark fins, they're truly having some bronchospasms going on. Now, we do have a lot of people that have wheezes. We have a lot of people here, God love them, that can fake wheezes really, really good. They breathe great. They go listen to them, and then they go. Then you have to tell them to stop it, and then they clear it pretty quickly. The guy from the alcohol unit. You got called him too, I believe. Yeah. He wheezes all the way to the truck till the door shut. And he's like, huh, going back to Pittsburgh. Really? So now we have a normal, a hyperventilation, hypoventilation, and of course a bronchospasm. You're going to see some of your emphysema COPD patients. Well, you'll also get some shark fins on them as well, secondary to same thing. Now, our intubated patient on CO2, this is where I think it comes into play more effective than anywhere else. I mean, this is a great thing when you're the one intubating the patient, when this little squiggly line does this number, when you couldn't see the vocal cords to begin with because of blood and everything else and puke. That's a great thing to see. I mean, that just takes a weight off your shoulders, even still today. That lets you know you're confirmed and you're in place. Now, really sad day when you get this and it goes back to this. That means the fireman got hooked up into your hose and he pulled your tube for you. We'll blame fire since they're not here. Capnography provides a continuous numerical value of the entitled CO2 with apnea alarm after 30 seconds. Continuous graphic waveform for immediate visual recognition. This is why we want the screen up here. Numbers are great, but you want to see the waveform. The waveform tells you so much more than what the numbers do. Like real time, if we were doing just entitled oxygenation, not entitled, but oxygenation on a patient, and this happened, how soon do you think you're going to know that?
As soon as the belly becomes a balloon.
As soon as you're like, what? Did a leak come off the monitor? Why are they innocent the leak? Yeah. When you're busy with code or whatever it may be, or an intubated patient that's critical, you got to have that waveform because those numbers just, you have to have them on CO2 because your oxygenation numbers will just, it'll kill. It'll rend your career in a hurry. Yeah, don't ever go off of just oxygenation alone if your patient's actually in trouble or if you think your patient's sick. Also provides documentation of correct placement of your ET tube, ongoing documentation throughout your patient care. You can print out any kind of trend on there to prove that tube is in place from point A to point B, and the ER pulled it out when they moved it. We also have video laryngoscopes as well. If I could ever remember to plug that thing in to record it, would be great.
Look with the,
It's a little,
no, you don't have to.
You don't have- okay,
They're
well,
recorded.
oh, good. Mine are all
I need to
recorded.
download all of them.
So. Yeah, I thought you had that little piece in there.
It's just a
All right,
transfer.
let's go back and not use them. It's great for assessing chest compressions, early detection of ROS. Like I said, as soon as you get a spike in numbers, stop CPR. Because you listen, if you have to listen to a stethoscope to the heart, it may be faint, whatever. But if you get it, you get an increase in CO2, you have a heartbeat. Without it, you would not have a CO2. You can always use the feedback on how the CO2 and depth rate for chest compressions during. They'll give you a line to follow. Higher the line, better compressions. So briefly stop and check for an organized rhythm. What happens? So, and this is something that I do a lot, is you intubate your patient, you get your CO2 reading, and it says it's between 4 and 10. That patient is not going to come back. If you can do your rounds of CPR and you can average anywhere from 25 up into the 30 or above 30, you have a good chance of survival. This is where I'm a firm believer you should intubate your codes, all your codes, regardless if you're going to transport it or not, because I want to know what that end title is. And the you call it the IGELs is too much dedication. So we can use capnography to titrate the entitled CO2 levels of patients, especially with head trauma strokes, brain tumors, and brain infections. Like I said, the big thing is about the head trauma is we want to keep that CO2 from rising. So we want to try to blow that CO2 off. We want to try to keep it, if you know that patient has head trauma, you want to try to keep it to the lower side of normal, probably the 30, 32, 34 range, if at all possible. That will help decrease brain swelling or at least slow it down so they can get to a proper surgery center to perform. Strokes, depends on where the stroke's at, whether you can even affect your CO2 or not. If it's in the brain stem, you have a really hard time controlling your CO2. If it's not, try to get them between 35 and 40 as well. Especially if it's a ischemic stroke, you can do very well with them. Brain tumors, another thing. Just try to decrease that swelling, especially if the tumors are growing, become more effective. And then brain infections, of course, it's just going to be scattered. So you have to take antibiotics to fix that. We're not going to do anything with it. But the ICP, we can't take care of in the field, or we can help in the field. We can't take care of it, but we can keep it under control until better hands can take care of it. So high CO2 levels induce cerebral vasodilation, which is positive increase of hypoxia to the brain. Negative increase of hypoxia increases ICP and may increase brain edema. Hypoventilation retains CO2, which really increases the level. So this is all this is saying is we need to get their CO2 to the lower side of normal so we can stop the swelling. So low CO2 levels in cerebral vasoconstriction. Positive entitled CO2 between 25 and 30 causes mild cerebral vasoconstriction, which may decrease ICP. Negative decrease ICP, but may cause an increase of cerebral hypoxia. So find that happy medium. And of course, hyperventilation decreases your entitled CO2 levels. Treatment goals. We're going to try to avoid cerebral hypoxia. Well, we're going to monitor our blood oxygen levels with pulse oximetry. We're going to maintain their CBF. Target end title is going to be 35, especially with head injuries. They don't want them any higher than 35 if possible. So our non-intubated patient. So they go to grandma, have trouble breathing. We do our assessment. So we're going to try to find out if she has a history of asthma, emphysema, bronchitis, pneumonia, cardiac ischemia, CHF, pulmonary embolism. What's going on with her? So we're going to divide the monitor of bronchospasm and asthma and COPD. It's going to look like what on the monitor? Shark fin. We're going to assess the monitor for hypoventilation states, hyperventilation, or low perfusion states. So our hyperventilation state is going to be what? What's it going to look like? Hyper. Hyper. There you go. And hypo. There we go. So on bronchospasm, air trapping due to irregular the airways, uneven emptying of the alveoli gases, dilute exhaled CO2, slower and rise in CO2 concentration during exhalation. Once again, still air trapping. It's going to come up. You're going to have the shark fin style waveform. And this is just going to go through and show you again throughout your phases here with the uneven emptying going on. Produces exchange in phase 3. This is our slope where we're having the unemptying that's not normal. Altered alveoli plateau. And of course, it makes the shark fin and we take inhalation. Drug of choice for this. What drugs do we carry on the ambulance that we can give to take care of this problem? Albuterol. Saw your metro help was not coming back. 2 more. Okay. Actually, I wouldn't think of that. No, there's still 2 more. I just don't like doing that part of it. Yeah. Still 2 more drugs we can get for this. Magnesium. I love it. Absolutely. Magnesium works great. What else? No, you're not. 1 more. Come on. It's an accelerant. Epinephrine. Yes. You can do either racemic or subQI. I guess we don't have racemic in our protocol, so we don't do racemic around, do we? Here, he's got stroke on it. So, capnography and asthma and bronchospasm. And this is kind of a real time. See how it still kind of looks like the shark fin? That's still what we're looking for. We're looking for that uneven plateau. Now, if they all looked like that, that would be great. We would never miss it. But anyway, after our breathing treatment, we should go from that to this if God aligns everything for us. And the patient should go, I don't want to go to the hospital. That's kind of unusual. We let them out. So, COPD. This is a fish of the new water here. Progressive, partially reversible, airway obstructed. Problem is with this, we have mucus glands with smooth muscles, excessive mucus production, and some hyper-responsive. Everything is great except for this right here. We don't like the mucus in there because guess what? We can't get rid of. We can't get rid of the mucus. So, but what we do is we vasodilate everything, and what does that happen? What happens to that patient after we vasodilate them? And you'll know if it's mucus because they'll start doing one certain thing really quick. They'll start choking it up. The ACO2 increases in the COPD disease process, requires frequent arterial punctures or ABGs at the hospital. Even when they go to their regular family physician appointments, they always check their ABGs, especially if they're a bad COPD. They should anyway. Assessing the phase on plateaus are altered by uneven emptying gases. Once again, as we talked earlier, you're going to have that shark fin aspect still because of unemptying. And then once, like I said, once we have a treatment, hopefully it comes back down. Even this one, you can see, it's not quite shark fin, but you still have that plateau that's altered. Still, we're having trouble. And this is how you know your patient's truly having trouble as well. I mean, you may get in there, and we've all had these patients that, oh yeah, I had trouble breathing for days now. It's been coming on for a week, blah, 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 blah. And you can't get a word in edgewise. Are these patients really having trouble breathing? Huh. Are they anxious? Absolutely. Maybe we should give them something to calm them down instead of give them something for the lungs. 88-year-old male, shortness of breath. MI times 2, oxygen in 2 liters, pulse is 66, current pressure is 164/86. His respiratory rate is 36 and labored. They're shallow, skin's cool, diaphoretic. 2+ pulmonary or 2+ fetal edema. SpO2 of 69%. And he has an end tidal of 17. What's your first thought?
Entitled low.
His end tidal is low. What's your first thought of his end tidal being low? One of two things come to mind. Either we have a cardiac episode that's severe, or he's got congestive heart failure.
Fetal edema.
Huh?
When the fetal edema, I leave more towards CHL.
Mm-hmm. So place on non-breather mask with 100%, 15 liters, sublingual nitro. You can turn him around from 69 to 99. His entitled CO2 went 17 to 35. Pulmonary edema. Hypoventilation states, alternate mental status, secondary to sedation, alcohol, drug ingestion, stroke, CNS infections, head injury, abnormal breathing, CO2 retention, or entitled CO2 of 50. Don't you love how head injuries on both sides of the spectrum there? You might tell me why. Why head injury can be low and high?
Or is the injury stack?
Well, the injury, that's exactly. Or how bad is the injury? So this is going to be a hypoventilation state. Tall, wide, and slow. We do not like this state. We would rather have the other state than the state. Hypoventilation and shallow breathing. You're going to have this right here. This is a nice, just nice, slow breath. Yeah, not good. You see this on your monitor, that's not good. What needs to happen, Jason? Google. They bought a plastic breathing device. So low perfusion also is a pulmonary blood flow, systemic perfusion, and cardiac output. Because all of this can cause low perfusion. So in another scenario, 57-year-old male, motor vehicle crash. He has injuries to his chest, history of AFib, anticoagulant, unresponsive, pulse is 100 irregular, BP is 88 over palpation, This patient's intubated on scene. Here's what you have. What do we need to do? What would you do? We can play this two different ways. He has a low end tidal. He's breathing what? He's breathing okay. He just has low end tidal. So he's a little hyperventilating.
He's intubated. Is he hyperventilating or are we?
Good question. That's a good question. Did they intubate him on sedation alone, or did they paralyze him? Say you haven't done anything, but you slid the tube in this guy. He's breathing, he's still breathing on his own. But you slid the tube in him. What do you think? What needs to happen?
Tube placement correct?
Yes, you have waveform capnography. Tube placement is in. Okay, what's the last thing we want this patient to do? We do not want him to do what? Okay, well, we don't want to stop breathing. It's a good point.
Rule number one.
Okay, if he's hyperventilating, he's blowing off CO2, correct? What we want in a head injury, we want him to blow off that CO2. We don't want him to get put down at 25, but still, what do we need to do to this guy? What's his issue?
Breathing on his own, isn't he?
He's breathing on his own. But what do you want to do? Sedate him, paralyze him. Take his breathing over for him. Because obviously he can't control his rate. Obviously he has a head injury of some sort.
But he's already intubated, so aren't we breathing for him?
No. They just studying how many people have you well, how many people you intubate without anything? You just go up and you just tube on scene without giving them anything. They're still breathing. Yeah, what we want to do is control his rate, control his oxygen input at this point. Let's take over his respiratory drive. Let's set him where we want him to be at and see what we get at that point. It may just be as simple as putting him on 40% oxygen and a breath rate of 16 to bring his end tidal back up to where he wants. This guy here, still going. So we get him knocked down, whatever it may be. Strong radial pulses and tidal CO2 seem to decrease alveolar perfusion. Probably I'm having a pulmonary embolism secondary to that shot to the chest. Are we going to fix that in the field? No. At this point, this is exactly what we said we want to do a while ago. We want to knock him down, take his breathing over, reset him to where we can try to get everything up to a normal standard so they can get in and take care of the pulmonary embolism. If he makes it that far. Elevated baseline. So we got oxygen mask on here, forehead and neck alignment, shallow breathing, not clearing the dead space. That all takes effect in your baseline evaluation. Just had this yesterday. Capnography and DKA. Rapid rate, normal waveform, elevated end-tidal CO2, early respiratory compensated DKA. Of course, it's, what was it, 916?
Yeah, East 8th Street.
East 8th Street. Once again, he's in DKA. Blood sugar was high. We pulled up on the porch. He just wouldn't stop puking. He's like, well, let's get him back one to the truck. But yeah, same thing. So what can we do for this guy? What are we gonna do for our DKA patient? What can we do for our DKA, baby? Pray for him. Would you like me to say hello, brother?
Yeah.
Your ass is good. Just goodbye. So we start IV on. IV fluids. IV fluids. We like fluids because the blood sugar is going to be high. What else can we do for them? How are we going to lower that potassium in that truck? What drug do we carry that'll help lower potassium? No. Albuterol. What else can we give to help lower potassium? If we wanted to go this far with it. Without actually knowing the level. It's really nice to have ice stats. Sodium bicarbonate. Both of those can help lower potassium, especially in our DKA patient. If we carry insulin, we can give them 10 unit insulin IV, followed by a bag of D10 because it's going to knock shit out of their sugar. Non-intubated patient. So we're going to be looking at the pulmonary emboli, congestive heart failure, DKA, bioterrorism, and maybe some others here. We can go through. So anyway,
So with like DKAs, when they're compensating like that, you usually just want to keep them at what they're entitled to add, or do you want to try and
if they're conscious and are able to take care of their own way, their own airway, I don't mess with them a whole lot.
yeah,
So the simple fact is you had a short run to multiple sets of hands. If you take a DNK patient that's conscious and alert, you decide to jack with him, you're probably gonna end up knocking him down and tubing him.
yeah.
Like I don't mind giving like the albuterol. It's not in our protocols. I mean, you can call in and they'll give you, they'll take just the continuous breathing treatment, or they should. That's going to help a little bit. It's not a cure all by any means.
Yeah.
If they're already sat in 100%, who gives a shit? You give them albuterol anyway because you're trying to lower that potassium level. So we're not giving it for the breathing problem. We're giving it to help with potassium. Sodium bicarb. I mean, that's going to be a judgment call. I wouldn't give it without knowing what my bicarb level was, what my pH is. I mean, there's a lot we can do. Fluids. You can dump a liter of fluidum in 5 blocks, dump a liter of fluidum in 5 blocks. I don't care if the pressure is 170 over 110. Dump that liter of fluidum because they're gonna need it. And if you're not 100% sure if you're even in DK, ask them how much you've been peeing. How thirsty you been lately? Oh, I see you have continuous vomiting. And we're all a great sign.
That may be why their blood pressure is 170 over 110.
Exactly.
They're dry.
They're dry, exactly. Just because your pressure is high don't mean you don't get your patient fluid. And you hear that all the time, and they teach that in paramedic school as well. Well, you want to hold off on your fluids if you have a high blood pressure. That's so much bullshit. I mean, now if you have a high blood pressure, say 200 over 130 or 120, and you have a heart rate of 150, now we have some issue because the heart can't take that. But if the heart rate's 80 and you have a blood pressure of 230 over 110, who gives a shit? The heart's going to be fine for a while until they're out of your hands.
As long as you don't have a headache
Oh, you don't have that. I mean, you're going to be okay.
or a stroke.
So, this is the test. What is this? Yeah.
Who could get?
Like I said, this test's pretty easy. Sudden loss of waveform. What happened to your tube? Gone. Or they just quit breathing. So it can be apnea, airway obstruction, dislodged airway, airway disconnection, ventilator malfunction, or cardiac arrest. Any of those create that. Let's please start with, before we jump on the chest, let's make sure our vent's covered. That would be a great thing. All right. We got going on.
I said they're breathing this time.
They're breathing this time. That's a good thing. So what's going on? It's increasing.
Shivering?
The trend. Increase in tidal CO2. Decrease from respiratory rate, hypoventilation, decrease from tidal volume, increase in metabolic rate, or rapid rise in body temperature, hypothermia, which will create shivering, of course. Yeah. So what's going on here? Diagonal. Tubing the esophagus. Low or no respiratory rate.
All priest.
No CO2 is present. Uh-oh. What's going on here? Increased baseline.
Is that the not clearing the dead space one?
It could be.
Mhm.
Or your patient could be rebreathing.
Trip.
Multi valve, inadequate nurse flow, insufficient respiratory flow.
Baby shark fins?
Baby shark fin, baby shark fin. Inadequate seal around ET2. A little more air in there. Leaky or deflated into crazy puff, artificial airway too small for the patient. This is one thing that you can do, like LMAs. Is they do capnography off LMAs, which is I don't know how they calculate that dead space, but like your anesthesiologist, that's one way they tell if the LMA is actually good fit for surgery, is they can get a seal or not. Because they get this if they don't have a good seal, so they'll change out your LMA so it's not. Or they'll try to inflate more air in. And you go up from normal to low. Doesn't look like he's getting any narrower.
Circulation.
Increased respiratory rate. This is not, that's one thing that'll do it, but this is not increased respiratory rate because it's not got smaller. Increased tidal volume could do it. Decreased metabolic rate, I would say, is what's going on here, or a fall in body temperature. Correction. Once again, kink tube, foreign body in the airway. This is what we don't want to see as paramedics.
Breathing on their own now.
Exactly. That right there is saying, hey, I'm waking up. Give me some more medicine. Muscle relaxation begin to subside, depth clip, pressure degree of the drug activity. Your patient is waking up. Any questions? That was pretty quick.
Be sure you go on the lead tech and fill out a evaluation form today. You can do it on your phone. No evaluation, no CEs.